Hmm? Yeah. Good afternoon, friends. We are seeing the progress and evolution of COVID pandemic all over the world, and we are learning every day some new information about this pandemic, including epidemiology, pathogenesis, pharmacotherapy, and now more about the vaccines. And uh, to improve care of children, we started 16 webinars from 15 October to 5th of November. And after that, there is a lot of information which is available regarding epidemiology, pathogenesis, treatment, and now vaccination. So we decided to have an update of this COVID care specifically for children. And uh, now I request our head of department, Professor A.K. Devrari, to say a few words about the importance of this ongoing activity and scope of this webinar. Sir, Professor Devrari.
Thank you, Sushil and Rakesh Lodha. I'm so happy to see that in the series of webinars which we are doing now every 2 weekly, this is the fifth one. And as we know that all over the world now we are worried about the new variant strains of COVID-19 which have come, especially reported from UK and South Africa. So we are worried how they are going to affect the children because the infectivity of this mutant virus is going to be much more severe as compared to the initial Wuhan COVID-19 virus. We see light at the end of the tunnel that vaccine is going to be available, but we know at this point of time the vaccines are not licensed for use in children because we don't have any trial which has included children. So we will have to wait for safety of the vaccines which are going to be launched in the entire world and whether how much immunogenicity they produce for certain conditions, comorbidities which are existing in the adults. Once that data is available, then finally the vaccination in children is going to come. So I am very sure Sushil and his team are going to deal with the new strain of the virus. In addition, they will talk about the vaccination. My advice to each one of you are three in number. Number one, what we need to keep in mind is we need to keep a watch on number one, newborn babies who are born to COVID infected mothers. Because lately I am hearing that newborn babies who are born may have even antibodies which are positive and they may have even cardiac involvement. So we need to have a watch on that. Number two is children who have suffered moderate or severe COVID infection, we must have a robust follow-up of these patients. Second thing, because we need to make sure that they don't suffer from long-term pulmonary or cardiac and other organ system dysfunction. Number three, I would say all of you need to work together to create a national registry of COVID infection, which is mild to moderate or severe in children, so that we have collaborative learning across all the countries. And I'm so happy that WHO CRO office is working towards that, and they have created a national registry in which most of the institutions are contributing the data. So I wish Sushil and Rakesh to continue these type of webinars because the new information is going to come over next 4 to 6 weeks, and we should be able to share whatever is the best evidence-based information which is good for our children care for COVID, and we should be able to share that. So I am happy on behalf of Department of Pediatrics and support from WHO CRO that we are able to continue this activity. And all the effort is due to Sushil Kabra and Rakesh Lodha, who have put enormous effort for making this happen. Over to you, Sushil.
Thank you, sir.
Yeah, thank you, sir. Thank you for your words today, specific aspects that you've highlighted, and also for the constant motivation and encouragement and the support for this particular program, and also a lot of learnings on the technical side of how to do these webinars. And at the same time, I'd also like to thank the WHO CRO office, particularly Dr. Rajesh Mehta, for the constant support and for this initiative. So as highlighted, since we did the webinar webcasts, there have been new developments on various aspects. And to cover those, we have planned to periodically do some small updates to just highlight the key changes. So today, we're going to be listening to Dr. Nitin Dochak, who's from Department of Pediatrics, who has put together the current state of knowledge beyond what was already known till about a couple of months back. And thereafter, we'll have a question answer session. So you could type out your questions and comments in the YouTube chat box, and we'll be taking these questions up at the end of the webinar. So with this, will initiate this webinar and take questions thereafter. Thank you.
Children, updated recommendations for management of COVID-19. Greetings. In continuation with our previous webinar series on COVID-19 in children, today's session will be an update of information. I am Dr. Nitin Dochak from Department of Pediatrics, AIIMS, New Delhi. I will be covering the current state of pandemic, risk factors of severe disease in children, updated recommendations for management of COVID-19, and what's new in the multisystem inflammatory syndrome in childhood. Vaccines, what is the current status? So if we see the global data, there are nearly 77 million cases worldwide with 1.7 million deaths. In India, the total number of cases just crossed 10 million and total deaths are around 1,46,000. Around 14% of all cases in India are less than 20 years. If we see the global situation, this is the situation according to the WHO regions, and what we can see here is that in the Asian subcontinent, the numbers are gradually coming down. This is an epidemiological study which was based on 2 states in South India, and what we could see here was that the children, there was less incidence of cases compared to the adults in India, which was congruent with the data available from United States. Also, the mortality was less in children compared to the adults and elderly population. Risk of transmission for household contacts was nearly 2 times compared to the non-household contacts. And sharing a bedroom and spoken to by an index case for 30 minutes or longer was significant risk factors for household contact transmission. And in non-household contexts, the risk of transmission was higher if there was exposure to more than 1 case, spoken to by an index case for 30 minutes or longer, or if they were sharing a vehicle. This slide shows the transmission dynamics in children. What we can see here is that if the index case is a child and the contacts are between 0 to 4 years, the risk of transmission is highest, and which is not seen in rest of the populations, and similar trends are seen in the elderly population. Reason for these could be failure to follow specific precautions in pediatric population and elderly population. WHO has issued a new guideline and they have classified the disease severity into non-severe, severe, and critically ill. In the non-severe patients, there are absence of signs and symptoms of severe and critical disease. Severe disease, there is hypoxemia, that is saturation less than 90% on room air. Respiratory rate is more than 30 per minute in adults and according to the age in children. And there could be signs of severe respiratory distress. If the patient is requiring life-sustaining treatment or is having acute respiratory distress syndrome or sepsis or septic shock, then such patients are classified under critical. Among risk factors for COVID-19 severity in children, infancy and underlying conditions or comorbidities are significant risk factors of increased disease severity. Among infants, what was seen that very less patients are asymptomatic. So 20% of children less than 1 year were asymptomatic compared to 39 to 45% of older children. And also infants had worse disease severity and they were more frequently hospitalized. There was shorter latency from symptoms to admission, which suggests that these patients have a more rapid course. This is a meta-analysis of severe COVID infection and pediatric comorbidities. What they deduced was that children with comorbidities, they have high risk for severe symptoms as well as high risk for mortality. And what they found was that obesity was associated with severe COVID-19 in children. Coming to treatment of COVID-19, there are no pediatric RCTs for therapies of COVID-19. A recent WHO recommendation has been issued on drugs for COVID-19, which is based on updated and compilation of available evidence. And what they recommend is that hydroxychloroquine and lopinavir-ritonavir, they do not find any role in treatment of COVID-19. Remdesivir, there is conditional recommendation against its use, but systemic steroids are recommended for severe and critically ill COVID-19 patients. And for non-severe COVID-19 patients, steroids are not recommended. Now we will focus on updates on multisystem inflammatory syndrome in children. So cumulative global or Indian numbers are not available, though there are multiple case series from across the world. The United States database suggests that there had been 1,288 cases of MISC and there had been 23 deaths. And with time, more and more atypical manifestations of MISC are being described. There are reports of acute pancreatitis, acute hepatitis, and raised ICP presentation for MISC. In a meta-analysis, the outcomes described were that need for ICU was in 71% of the cases, need for mechanical ventilation was in 22%, ECMO was used in 4.4%, and overall mortality was 1.7%. American College of Rheumatology recently updated their guideline for management of MISC. The basis for this is because of the rising community cases, there will be children with mild form of MISC. Also, due to increasing baseline SARS coronavirus 2 IgG positivity rate, unremitting fever in children could be overdiagnosed as MISC. So the stress for new guidelines is on the evaluation of common etiologies, stepwise tier 1 and tier 2 evaluation, and stepwise immunomodulation. So any child who has unremitting fever more than 38 degrees Celsius, epidemiological link to SARS coronavirus 2, and clinical features suggestive of MISC. If all these are present, then you have to see the severity of MISC. So we have to evaluate for alternative etiology because MISC can mimic tropical infections also. Also, we have to evaluate if there is any life-threatening condition or if the child is in shock. If the child is in shock or there is life-threatening manifestation, you will do the evaluation of tier 1 and tier 2 simultaneously. But if these are not there, then you can have more stepwise evaluation. So you will do tier 1 evaluation, which will be a screening investigations. If they are positive, you will proceed with tier 2 evaluation. If the screen is negative, then you have to evaluate for alternate diagnosis. Also, you should monitor whether the patient further develops MISC because the course of MISC and the symptoms are still evolving. The tier 1 investigations include a complete blood count, a complete metabolic profile including LFT, RFT, blood gas and glucose, CRP and or ESR, SARS coronavirus 2 serology or PCR. A screen is taken positive if both of these are present. So either CRP more than 5 milligram per deciliter or ESR more than 40 millimeter per hour should be there, and at least one of these should be there. So there should be either lymphopenia or thrombocytopenia or hyponatremia or neutrophilia or hypoalbuminemia. If the screen is positive, then you proceed to tier 2 investigations, which include a detailed evaluation of the cardiac system. So that will include ECG, echocardiogram, BNP and TROP-T. Also, there will be complete evaluation for inflammatory markers, including procalcitonin, coagulogram with D-dimer and fibrinogen, LDH, triglyceride levels, and cytokine panels as available. Also, there should be a blood smear examination for any hemolysis, and SARS coronavirus 2 serology and PCR should be done if not already done. According to the new ACR guidelines, the treatment should be as follows. So if there is a hospitalized patient with MISC, you should see if there is shock or organ-threatening disease. If that is present, then you give both IVIG 2 gram per kg and methylprednisolone 1 to 2 milligram per kg per day. If the disease is refractory to this treatment, then you can consider high-dose methylprednisolone, which is 10 to 30 milligram per kg per day, or high-dose anakinra. If shock or organ-threatening conditions are not present, then you will give first-line therapy as IVIG 2 gram per kg according to this guideline, and in refractory disease, you can proceed with methylprednisolone or high-dose anakinra. But there are concerns about first-line agent between steroids and IVIG. So the ACR guideline recommendations are based on consensus and are derived from Kawasaki disease experience. There is no head-on study between steroid and IVIG in MISC, and high cost and availability in remote areas goes unfavorable for IVIG. But there are some concerns with steroids in view of frequent tropical infections mimicking MISC, especially in developing world. So what we recommend is that for patients who have MISC with shock or life-threatening disease, we can give both steroids and IVIG along with covering for infections with antimicrobials, and simultaneously evaluate for tropical infections. If there is no life-threatening disease, then first you rule out tropical infections and then give steroids 1 to 2 mg per kg per day, which should be first line, and IVIG can be either used an alternative or a first line as per availability. In antiplatelets and anticoagulation, aspirin can be used in dose of 3 to 5 mg per kg per day, maximum of 81 milligram per day. Indications are thrombocytosis and coronary aneurysm with Z score more than 2.5. Enoxaparin can be used as anticoagulant with the target factor 10A levels of 0.5 to 1. Indications are large coronary aneurysms with Z score of more than equal to 10, thrombosis which is diagnosed and established, and severe cardiac dysfunction with the left ventricular ejection fraction less than 35%. Cardiac specific recommendations include ECG should be done every 48 hourly, echo should be repeated at 7 to 14 days and 4 to 6 weeks. If there were abnormalities on the initial echo, then it should also be repeated at 1 year. Optional investigations are cardiac MRI at 2 to 6 months if the initial ejection fraction was less than 50%, or cardiac CT if we are suspecting some distal coronary aneurysm. Now a brief overview of COVID-19 vaccines. So what we have seen is that there were various targets for the vaccine development, which included DNA, RNA, proteins, non-replicating viral vectors or inactive virus, and more recently live attenuated virus also. This was a recent publication of safety and efficacy of BNT162b2 messenger RNA COVID-19 vaccine. They included healthy population aged more than 16 years, and 2 doses were given 21 days apart. And this vaccine showed efficacy of 95% with confidence interval of 90.3 to 97.6%. Adverse effects were short-term and mild to moderate pain at injection site, fatigue and headache. Serious adverse events were similar in the vaccine and placebo group. So there have been various vaccines which are approved for emergency use, and the vaccine that we discussed in previous slide has been approved for use in UK, Bahrain, Canada, Mexico, US, Singapore, Oman, Saudi Arabia and Kuwait. And the age is more than 16 years for this vaccine. Another vaccine, the Moderna vaccine, has also received US FDA emergency use authorization after review of trial data, where it showed efficacy of 94%. And it is approved for using in age more than 18 years. Various other vaccines have been approved in different parts of world, including CoronaVac, Sputnik 5, BBIB, CorV, and EpiVac Corona. In Indian scenario, the front-runner vaccines are Covishield and Covaxin. Covishield is being tested by Serum Institute of India, which is a non-replicating virus particles, and the phase 3 trial enrollment has been completed. The Covaxin was developed by Bharat Biotech, which is a whole virion inactivated SARS coronavirus 2 vaccine, and phase 3 trial enrollment is still ongoing. There are still some concerns of vaccination in children because the trials are not including children and adolescents, and dosing is an issue in immunocompromised individuals. Whenever children are being immunized, there should be a priority given to children who are at risk for severe disease, which includes obesity, medical complexity, genetic disorders, neurological disorders, metabolic disorders, sickle cell disease, congenital heart disease, diabetes, chronic kidney disease, asthma and other chronic lung diseases, and immunocompromised children. So to summarize, COVID-19 numbers are decreasing in Asia, but there is a significant health problem. Steroids are first-line drug for severe and critically ill patients with COVID-19. No role of hydroxychloroquine, lopinavir, ritonavir, and remdesivir. And we are seeing more and more cases of atypical manifestations of MIS-C. We should go for a tiered approach for MIS-C evaluation and management. Early recognition and immunomodulation is key to improving outcome. And effective vaccination is the key. Thank you.
Okay, yeah, so I think we just heard the summary of whatever's happened in last few weeks. And another, I would request you to kindly write down any queries or comments in the YouTube chat box. So what Dr. Durari was mentioning was about report of a new strain or a variant or a mutant that's been come up from the United Kingdom, wherein now more than 1100 cases of this new variant have been reported. It was first identified somewhere in the month of September, and gradually the proportion of all cases which are being sequenced or genotyped, this particular strain seems to be increasing. A similar strain has also independently been reported from South Africa. So possibly these have emerged independently, and it's not like transmission from one geographical area to another one. We know that SARS-CoV-2 is a RNA virus, and mutations or changes in the sequence are not uncommon. And even in the target protein or the spike protein, thousands of these variations have so far been reported, but possibly they may not have been much impact on the transmissibility or the disease severity. Now, coming back to this particular strain that's been reported from the United Kingdom, it appears initially that the transmissibility may be higher than what is usually seen. However, as of date, there are no data to suggest that this strain is likely to be causing more severe disease. But we need to watch out for this. So, in response to this particular strain detection, there have been multiple restrictions that have been imposed. The isolates or whatever positive samples are now being sequenced. Even within India, there have now been a few reports of such strains being identified. And one would have to effectively continue with the specific preventive strategies, the general preventive strategies that we have been doing all along. As this time point, it appears that the vaccines which have been developed, they are likely to be effective against the new strain also, but we'll need to see with time. Because the antibodies are generated against multiple epitopes on the spike protein, and therefore it's likely that the virus is still going to be neutralized. However, as happens with other viruses like influenza, if there are major changes in the genome of the virus, the vaccine strains may have to be modified. So this is the current state of, let's say, information regarding COVID-2 and with specific aspects related to children. Importantly, the new vaccines have been on the horizon, and only thing is that at this time point, it's mainly for adults. For pregnant women, for children less than 18 years, we still don't have trials. Some trials have been initiated. So let's look forward to more data, and accordingly, one would have to draw out a list of kids for whom vaccination would be a priority. So I think with this, we'll start taking up a few questions that have come up. So maybe Nitin, would you like to address this? That the eye symptoms that may be there, and specific question is about a pink eye or a red eye with COVID-19.
So pink eye, which is like technical term for that, will be a conjunctivitis. So that is can be one of the symptoms of COVID-19, and also one of the symptoms of the multisystem inflammatory syndrome. But it is mostly present with other symptoms and usually associated with other respiratory symptoms or other systemic manifestations of COVID-19. But for MISC, this will be can be taken as one of the symptoms, not in isolation, but in association with the other symptoms.
Okay, thank you, Nathan. So I think we have one question about, now it's the vaccine part. So we have a question that in the scenario of increasing herd immunity, should we go for vaccines? So Dr. Kabra, would you like to elaborate?
So if we really want to control this pandemic, at least there should be more than 70% population immune to the infection. And that's why with natural infection, there may be small proportion who have already got an infection, and to have a herd immunity to control this pandemic, we need to give a vaccination. And as there is a limitation of the availability, and then the process of delivering it, it should start in phases. Like first, it should be for the high risk group, and then our aim should be that we immunize all the people so that we have more than 70% coverage of vaccination, so it becomes a herd immunity.
So yeah, I think these questions are likely to come up, and but I think as of today, the way we understand and the overall population, so I think one would still go ahead with vaccine, and coverage of the target population may take some time. Till that time, we need to continue with the usual precautions that have been highlighted for prevention of respiratory infections, and so on. So we have another question related to what are the chances of having MISC after vaccination? That's an interesting question, and it may not be easy to answer at this time point simply because we do not have any data on response of how children respond to vaccines and over a period of time. And I think one would rather wait and watch for trials and other data coming out from this rather than specifically be able to address this question at this time point. But it's something that one needs to look out for when children are being vaccinated, and they should be followed up, one for the disease part, and also whether any of these children have any risk of MISC. So we have another question, which is I think any timeline for COVID-19. I'm not sure what it actually means, but it could mean the course of COVID-19 in children, or it may mean how the pandemic is going to really, pan out from here.
As far as pandemic is concerned, it is going to stay. It will flatten, and the case rates, the infection rate will come down. But it is likely that we will continue to have cases of COVID-19 infection over next few months to years. And for that, we have to observe due precautions and get the vaccination. whenever they are available.
Right, sir. So there is again, it's about vaccination and again pertaining to adults. What about vaccination of people who already been infected in this year with
Yeah,
COVID-19?
as of now, we do not have a clear understanding about for how many months, weeks, or years, or whether it is a lifelong immunity against this reinfection. But there are cases which have shown that there is a reinfection. So that's why now broader understanding is that even if someone has got an infection, documented infection, he or she, if he comes in the high risk group, they should be offered a vaccination.
Yeah, so I think at this time point, whatever strategies have been developed, I think they plan to test people for antibodies or whether they actually are carrying antibody before vaccination. That screening is not envisaged, but whether people who had documented infection or were hospitalized, whether they should be, I guess the issue around the duration of immunity and all is likely to play a role in that. So at this time point, there is no selective vaccination of only those who didn't have infection or ruling out those who had a confirmed infection. Nitin, is another question about symptoms of COVID-19. Is there any particular order that would be there for symptoms?
So, most of the patients, they come with the fever and some of the respiratory symptoms for COVID-19 in children. And children, they have lots of mild illness. So some of them might just have some upper respiratory symptoms or just a non-specific fever without any localization also. But there is no specific order for these, but children can also have mild infections also. And most of them are mild infection only.
Okay. So again, I think vaccines in children we have already talked about. I think till the initial studies which have been done, like for Pfizer, it was for individuals more than 16. For other vaccines, it's more than 18 years of age. And now trials have been registered for children beyond 12 years of age. So we'll really have to look for data that is going to come in. And accordingly, one would have to take a view in the so-called category for high-risk population. There also needs to be kind of dosing studies for high-risk population which have who are immune suppressed or immune compromised. For example, patients on cancer chemotherapy or steroids. So there, in addition to the safety, there would also have to be studies on the dosing, whether the same dose is as effective or we need to work with higher doses. That data is to be looked at. So there are now other questions related to ivermectin. So, sir, what's the current status of knowledge and recommendations regarding ivermectin or high dose ivermectin? Similarly, vitamin C is what people are asking. So maybe, so what are the current thoughts?
Whatever information is available for ivermectin, theoretically it was considered that it may be useful, but whatever information we are having, it suggests that it is of no use, whether it is a low dose or high dose, whether you are giving it in a mild disease or moderate disease. Same thing is, there is hardly any evidence to support that taking vitamin C, zinc, or other drugs may improve or alter the outcome or may prevent the infection. So that's why all these medications are not found to be very useful for either treatment or for prevention.
Right, sir. So then there are a few questions related to the what happens in COVID-19 in children with asthma and other things. So I think at this time point there doesn't seem to be any excessive predisposition like other viral infections which may induce a flare or exacerbation of asthma. The same thing may happen with COVID-19. A few questions regarding the follow-up and what happens in the future. So I think this is an ongoing work where we need to look at a long-term follow-up, particularly for children who had significant respiratory disease, and other aspects also will need to follow up. So I think next few months we are likely to have data coming out on these kind of studies as well. Uh, then we are, again, a question regarding vaccine. Lactating mother be vaccinated for COVID? So the same thing at this time point, the trials have not included pregnant women, or I think even lactating women have really not been represented here. So if anything, one would extrapolate. at this time point, the safety part may be and safety efficacy part may be similar. The safety thing would have to still be looked at in pregnant women and lactating women. Nitin, there's a question about, I think this may be again referred more to adult patients. As COVID patient, can we take blood thinner on first day, so less chance of or less chance of respiratory problems?
So, it should be taken in consultation with the specialist and only recommended for patients with the severe involvement as of now, or if there are features suggestive of disseminated thrombosis in form of like investigations like a rising trend of D dimers or a high level of D dimer more than 2500, but not in all cases, only in patients with the severe disease.
Yeah, so I think one has to be careful. Many of these drugs are likely to have side effects also, so one wouldn't really go ahead and empirically use these. And I think that's one of the important things to look at is that the mainstay of therapy still would be supportive care. And as has been highlighted, I think I would also ask Dr. Cabra to chip in as to, we need to look at now that almost 8-9 months have passed, and there are a lot of publications and there is evidence. I think gradually we should be, moving more towards management, which is more evidence-based, but the background still remains strong supportive care.
So regarding anticoagulation, WHO's living guideline also suggests that it can be given in moderate to severe or critical disease only in selected patients, and the doses should be routine prophylactic doses rather than the intermediate or high doses, because they have been found to be associated with increased evidence of bleed.
Right. So I think we just still need to kind of now have a management approach which is based on at least some kind of evidence. And even if we are not very sure about specific antiviral drugs which may work, I think a lot of patients are now, doing better than what they were at the beginning of the pandemic, and that's mainly due to more protocolized care or supportive care in the mainstay. Uh, yeah, so maybe Nitin would like to talk about, I think, vitamin C specifically, or yeah, okay, yeah, go ahead.
So there's one question about role of vitamin C in treatment of COVID-19. Again, as of now, there is no evidence-based recommendation or evidence for any role pro or against use in COVID-19. So what will help is good nutrition and good hydration and rest during the treatment. Specific micronutrients have not proven to be any beneficial role. And there is also that, so the treatment for mild illness in children is again, yeah, it is supportive care only in most of the cases.
Okay, so we have, I think we'll take a few more questions as they come in. This relates to the detection of the new strain and whether, there would be an impact on recommendation on the reopening of schools.
So it may have some impact, but as we understand, this pandemic will decrease, but it will not disappear completely in few weeks or months. This is going to stay with us, and reopening of our workplaces, schools, hospital working, or for non-COVID work, will require universal precautions, including masking and having a sanitization and social distancing, and gradually it can be opened up. As far as specific for the schools, it would depend on the infection rate in the community. This may have, the new strain may have a little impact, but not significant impact. It would be that how much is the transmission in the community and how much we are able to control the infection rate, and how much we will be able to implement the universal precautions, including mask and sanitization and social distancing.
Right, sir. So again, there's a question about, protective antibody titers after vaccination. So I think we wouldn't have very specific data at this time point. What these studies have typically done, they have documented immunogenicity, which would be at least a 4-fold rise in the antibody titers that would be done. And the efficacy kind of comes in from actual case detection. So at this time point, the antibody levels may not be, very correlate with protection of certain titer. That data are not there. What we also need to understand is there would be a role for, both the antibody or the humoral immunity as well as the cell-mediated immunity in protection. Antibody measurement is easier to do and can be done, but it always may not give us the specific answer. And once large scale vaccination is rolled out, I think one wouldn't really be doing antibody titers to figure out, because we do know antibody titers may wane off with time, and there still would be memory cells which are have the retain the ability to respond to a new exposure. Nitin, would you like to talk about, happy hypoxemia part in children, means so-called happy hypoxemia? Has that been described in children?
So most of the children so far described is that hypoxemia is usually proportional to the respiratory symptoms and other respiratory signs like respiratory distress or so per se only hypoxia without features of respiratory distress is not reported for children as of now. So most of the times what we should do is we should do a complete examination and watch for all the findings including saturation and features of respiratory distress. Just hypoxemia without other features is not yet described for children.
Okay. So now we also have the situation where children may have, co-infections, or, let's say there's a child with dengue is also detected to have, PCR or CB0 positive for COVID. How would one manage this child? So, sir.
uh, Co-infection may have an implication as far as first thing is regarding diagnosis, because there may be some overlapping clinical features in form of say fever, thrombocytopenia, leukopenia. However, we have not yet got any good information regarding one affecting the other as far as the outcome is concerned. So it would be supportive care for both these conditions. There is no specific antiviral or other specific treatment. It would be supportive. So if a child by any chance has both these infection, should be monitored very carefully. For dengue, we may have to give more fluid with monitoring, and at the same time we look for complications of COVID. As such, fortunately in children the disease is less severe, but still if there is a hypoxia and if patient is going into a acute respiratory distress syndrome, then we have to give a appropriate care. So overall, if you find that a patient is having both the infections, first thing is a very good monitoring, so that you can decide about the fluid infusion rate, and at the same time looking for the complications of COVID in form of a ARDS or other respiratory support. So both these things, preferably the child should be kept in a ICU if available. Otherwise, ensure very good monitoring and treatment for both the conditions, for ARDS shock as well as for IV fluid infusion rate.
Right, sir. So maybe another question is related to, can we differentiate symptom signs related to allergy and COVID-19? So that's a common thing that some children would get these kind of symptoms,
Say,
particularly nasal symptoms or breathlessness. So what should they do at that time?
say as far as allergy is concerned, it would be more of a nasal symptoms along with throat symptoms and less likely to have a fever. At the same time, if it is a COVID infection, more likely to be a throat infection, throat problems. Along with that, there may be a fever. However, these are very soft. If we see the epidemiological data, then it suggests that children with COVID may have a more likelihood of getting manifested fever, which would be transient, 1 or 2 days. There may be less of a sneezing and nasal symptoms, but it is not an absolute thing. There may be more increased symptoms of gastrointestinal symptoms in form of a diarrhea or other thing, specifically in younger infants and children. So it is very difficult to differentiate between these two. Keep a high index of suspicion. If there is a contact with the COVID positive patient, even if patient is having a mild upper respiratory symptoms, think of COVID infection rather than allergy. In the background of allergic diathesis, no history of contact with a COVID infection, known COVID infection, and child is having more of a cold, coryza, sneezing, then with a background of allergy, you are justified in saying that we can observe the child and give a anti-allergy treatment in form of antihistaminics or other treatment, whatever the child was getting.
Right, sir. So I think there's another question about genetic or ethnic predisposition to severity. So I think the initial kind of reviews, and again, that came from the Western world, that seemed to suggest that as compared to the white population, the blacks, the Asians, and the minority ethnic populations there had a higher severity of illness. But I think I think this data needs to be looked at. If you look at the overall outcome rates or overall mortality figures, somehow, at least in the South Asian region, they seem to be lower than what's been reported in the Western world. And there may be other reasons, including the age profile and, the population pyramid structure. So I think this still needs to be looked upon with a little bit more care. I think this part has already been talked about. I guess the differentiation between common cold and few other things is, I think, similar story. One would have to keep a suspicion. Is what.
So as so more clarification that if there is a definite history of contact with the COVID patient and the child is developing cough, cold, coryza, more predominantly even nasal symptoms, think of COVID infection and investigate and observe due precautions in form of isolation and treatment. If patient is having an allergic background and no history of contact and gets this upper respiratory infection, clinical symptoms of coryza, cold, sneezing, in those situations, you are just without any fever, you are justified in treating them as a known COVID, give antihistaminic, but at the same time, as it is highlighted repeatedly, they think of similar other infections, including influenza and others, because that is now common in this season.
Right, sir. So I think, okay. So there's a question about an update for use of PP in the OPD and wards looking after mixed group of patients, including COVID. So I think as we move forward, I think we would have to, the services would have to be normalized. Maybe many of the hospitals, many of the settings, and for inpatients, they are screening patients for COVID infection. And if they have COVID infection, they manage in a separate facility. And at the same time, there would be instances where somebody who's admitted with not so-called, detected to be COVID negative to begin with, may subsequently be detected to have COVID. So, and also, because there's a risk of, there's a possibility that even the personnel, the healthcare personnel, the support staff, the families, some of them may be carrying, the COVID infection, but they're asymptomatic. So I think we'll need to have adhere to a certain level of PPE for, at least some time to come, and which mainly includes the respiratory protection. So that's something that we would have. So the masking part would have to be there, and wherever, particularly using an N95 more so in a setting where the aerosol generating procedures, using a face shield when, let's say, suction has been done or nebulization has been done or somebody has been intubated, these precautions would have to be done. Now, same thing is true for an OPD setting. I think we would have to adhere to certain level of protection. Again, the mainstay has to be, the focus has to be on the respiratory PPE. Whether one should be means, so in a routine setting, one is not using a whole body coverall setting. One would be looking at, maybe using a gown. And the same thing may be applicable in our OPD setting as well, because there the number of exposures may be, larger. And in children, particularly, respiratory symptoms are not uncommon. So one would have to make sure that we take precautions for at least, next few months, or it may be the next year, definitely. Uh, so again, I think this is a general question. Any specific nutritional supplement to boost child's immunity during COVID-19 infection? So I think I can kind of answer that partly, but I think specifically with this question that whether there is a nutritional supplement for immunity.
So instead of specific nutritional supplements, we should focus on a balanced diet during this and proper hydration. And so a balanced diet which also contains all the micronutrients also. So
a good amount of vegetables and fruits. So that will help in keeping a child well nourished, and the immunity will be appropriate. Per se, as of now, no nutritional supplements are recommended for prevention or boosting the immunity as of now for children.
Yeah, I think a lot of products are being marketed with specific things about the raised immunity and so on and so forth. But I guess these are just very general kind of conclusions, and more often used as marketing tactics than any specific evidence to support usage of any of these for a preventive thing. I guess making sure that the child is well nourished, making sure that the child is getting a balanced diet, that's more important in general for prevention of infections. Not just COVID, in general for prevention of infection. These good nutrition is a component.
And infection prevention strategies,
Yeah,
like
that's
as
the
much as they can be incorporated in our daily lives, so that will help.
yeah. So only thing is that there is like for very young children, like routine masking and all is not recommended. But then the rest of the family members have to be taking those precautions, and one would be avoiding movement to areas where there is crowding, or maybe people are moving without masks and so on. I think that would be the main thing. Uh, is there a management update regarding increase of psychiatric issues in children isolated in ICU or COVID ward setting? Would you like to add
So,
this, or?
again, like most of the settings where children are admitted, they are mostly admitted along with the one attendant, adult attendant or caretaker who's be taking care. And the psychosocial support is very important in any child who's being exposed to a critical care settings. And so there should be proper care for that. And as much as possible, there should be provision for entertainment, especially for in a pediatric ICU or admitted pediatric patients.
Right, sir.
More and more data are now coming regarding a long-term psychological impact on children as well as adults who were treated in ICU or isolated from their family members. And longer the duration, more problem. If there is a previous psychiatric problem, it is more problematic. So that's why it is important that once the patient is out from the acute illness, acute crisis, we need to have follow-up of these patients for various ailments, not only say physical elements of cardiovascular, respiratory or others, but specifically for the psychologist also. So wherever there is a possibility of getting, if there is a psychological problems, getting a consultation with the experts, it is important. But we should keep in mind that these patients may have a long term sequelae that we need to follow them and document it and provide appropriate support with the whatever experts are available in particular field.
Right. So I think there's another question related to use of masks in children. So I'll just briefly, the guidance that is there currently is that this is to be not recommended for children less than 5 years of age. Children who are 12 years or more would be similar to what is done for adults. It's almost like universal masking, particularly when exposures are expected, which may mean that moving to crowded areas or where distancing cannot be ensured. For children less than for 6 to 11 years of age, it is conditional in a way. It depends on the child's ability to use a mask properly, whether there's an adult supervision, and whether other measures can be taken care of. So that would be conditional in a way, but beyond 12 years, it's the same as for adults. Nitin, there's some questions regarding D-dimer, any specific treatment value or value for treatment.
So levels more than 2500 or levels more than 1500 with rising trend in patients with the severe illness or those requiring oxygen therapy, then we can consider, as long as there are no contraindications like active bleeding or severe thrombocytopenia, then we can consider for a low molecular weight heparin.
Also, so again, there's a question, is there any safe level for IL-6 or D-dimer? So first question would be, In what scenarios would you do IL-6 or D-dimer? Should it be done as a routine in all patients who are diagnosed to have infection or only in a subset?
So there is no per se, there are no well-defined cutoff, and you will do especially in patients with the severe COVID infection or patients with the MISC who are positive on initial tier 1 infection or tier 1 investigations, or if they are having severe illness at outset with organ threatening or shock. And in such patients, you will go ahead with the IL-6 and this D-dimer levels for these patients.
Right. So I think, do we have, I think that's the last question that we had. So maybe I think we would like to wind up now and maybe I
And
request.
these are available.
Yeah. So just this particular webinars on YouTube, the links there. In addition, all the previous 16 webinars are now available on YouTube. The links for these can be found on the AIMS website. It's aims.edu. And on the right upper corner of the page, there's a link for information related to COVID-19, and wherein one would find this webinar series page. And that page gives you the individual links to all the 16 webinars. So one would need to just download this information sheet, and from this PDF, one clicks on the link for the specific topic that one is interested in looking at, and one could be viewing the that particular webinar. So I think with this, I would like to request Dr. Kabra for his closing remarks.
So as we have already discussed, these webinars are available on YouTube of AIMS Telemedicine. You can just go and visit and see these things. And we are very thankful to World Health CRO Office of the World Health Organization, who have supported us and encouraged us to do this thing. If in future, if there are more information, we'd like to have more webinar series. Thank you very much for your attention.
Right. Thank you.